The American Metaphomics Association has talked about the increasing rate of doctors missing simple risk factors that can identify patients of cancer earlier. Why? Because the data is fragmented all over the place. And we all know that if we can detect cancer earlier, or most illnesses earlier, we've got a better chance of being able to go and address that. So really, our doctors are seeing a broken picture of the patient. I think if you look at age predictions, by 2050, that's only 30 years away, 1 in 6 people will be over 65 years. What does that mean? That means the tax base for governments goes down because less people are working. But if healthcare costs is rising up and the tax base is going down, and we all know that as you age, you're going to need more and more healthcare requirements. So really, we've used data to solve lots and lots of things in our everyday lives. There's a myriad of challenges that you see here that's facing the healthcare payers and facing the healthcare providers. There's a complete disruption in how payers and providers and patients interact with each other. How do we profitably mix and bill for personal care versus digital care? How do we do that? Who invests in the infrastructure, the digital infrastructure that is required for this? What about security? What about governance? What about privacy and regulation? There's all of these aspects that absolutely need to be factored into that. Now, we could sit back and be paralyzed and be, paralysis through analysis, if you like, or we could actually take some action. And what we do see is, yes, there's lots of things we need to address. Yes, there's lots of challenges we need to take on. However, we're also seeing a lot of innovation in this space. Keeping the goal in mind that the patient is at the center of this interaction, it's now really possible for us to help providers to start building in some operational efficiency, to start improving their patient engagements, to start looking at value-based care and how to go about doing that. And also to look at efficient interoperability between these systems. And this, I'm prone to this. So I have a genetic predisposition I'm of Indian descent. I have a genetic predisposition to diabetes. Now, when you have diabetes, your extremities, your fingers and your toes can get ulcers and they can get infection. As a byproduct of that, your vision also gets a little bit blurry. So if I were to look at my finger, I wouldn't know I had an ulcer there because you lose the sensation, your vision is blurred, you don't even know you have it, and you would just ignore it. If you ignore it, the ulcer becomes cancerous, and at some point it has to be amputated. So what we did with Manchester University is we worked with podiatrists throughout, and we took all of the images of what a good or a bad ulcer looks like. And we fed that into the cloud, and we used machine learning and AI, and we now can predict from an image whether or not that ulcer needs to go in for treatment or whether it's not dangerous and you do not have to go in for treatment. So now it's a simple app. So if I'm a diabetic, I take the phone, I do that, take a photo, and it's applying machine learning, and it's coming back and telling me with a significant amount of accuracy whether or not I need to rush in to the doctor, because I can't feel anything, or I don't have to rush in. That's a significant use of machine learning and AI, very simple technology. Over the course of the pandemic, I said we invested a lot to get closer and closer to get to the outcomes. One of the systems we rolled out was a system called vSafe. Now, vSafe was an online system where anyone who received the vaccine could record adverse effects, either on their smartphone or web browser or whatever. And this system, by the way, we rolled it out in 68 days. From thinking about it to production was 68 days. Over 1 million people were hitting it every day. And they just said, I had the vaccine. How do I feel? Do I have a fever? Do I feel good? Do I feel bad? And we captured all of this information. Now, when they came to vaccine trials, of course, when they were doing trials for the vaccine, they said, pregnant women should not take the vaccine as a trial because they didn't know the adverse effects. But it turned out that 130,000 women who had taken vaccines, but when they took the vaccines, they didn't know they were pregnant. But we had the data now. So they came back later and said we were pregnant. So what it meant was we were able to accelerate that data gathering process and then apply that with machine learning and see whether or not the vaccine was safe for pregnant women, right? So it's applications are this. We didn't know we had that data. We weren't trialing it for pregnant women, but looking back, the ladies came back and said we were pregnant at the time, we got the vaccine, and we could now start looking at the adversity, whether or not that's effective. You can imagine the impact of this. We were able to roll out or reduce the risk, or at least make people aware of the risk of taking that treatment, of taking that vaccine during pregnancy, or if they have a predisposed condition. This is all good, but I also wanted to say, looking ahead of the curve is also really, really exciting. So throughout this process, what we have done is we have worked with the University of Oxford that you see there, and we have classified or codified not just COVID-19, we've classified in the common influenza strains and all of the virus strains, working with the University of Oxford. And the system that you see there is called GPAS, Global Pathogen Analysis System. I think the website is gpas.globe or gpas.world. And in GPAS, we've codified all of this, and we're able to then use this when we see flares up, because we keep refreshing this data based on the vSafe system. We keep refreshing it. When we see flare-ups, we're able to look at what's the next variant of the virus coming out. So the GPAS data is the one that detected earlier on the Omicron and the Delta variants of COVID-19. And by predicting ahead of time that that was coming out, we were able to work with the healthcare officials and policymakers to say, how big is Omicron? What should we do? Should we plan for stay home or not? Because we can see, based on the codification of the virus, as well as the patient information of what the potential impact would be using machine learning models. So again, GPAS is something that we've made. It's completely at no cost to researchers and non-profit organizations. They can access this data, they can use this data and build out their machine learning models on top of this. So we talk a lot about data, right? If the future of healthcare is about putting the patient back in the center, the future of the healthcare then depends on data as well. And we need data to make these sorts of assertions. You can't pick one part of the population for data because the machine learning can't accurately predict what's going to happen for the other side of the population. So for machine learning and AI to play a role in healthcare, the data needs to be global, the data needs to be distributed, it needs to be diverse, different cultures, different ethnicity, different language. It needs to be seamless collection of data. And again, working with providers in the 5G space, that's exactly what we're doing. We've extended our patient systems to capture that information so that now the machine learning is not just being fed by one small demographic, it's being fed by a diverse range of data. The more diverse the range of data, the better the accuracy of machine learning, because you've got a rich population of data.